Cảm ơn giáo sư tiến sĩ Long, Hàn và Kevin để cơ hội hôm nay để thăm Việt Nam Hà Nội lần đầu tiên, với lại Vinh rất hân hạnh để có thể tham dự cái học hôm nay. But now I will change over to English, which is much more comfortable for me. So Drs. Mori and Amanda talked to you about the pathophysiology and diagnosis of functional dyspepsia. My goal for the next 15 minutes is to put together everything that they talked about and review the GI pathophysiology and really think about how that physiology or that the abnormalities can help guide our therapies and think about the diagnosis a little bit more and provide a framework. And I recognize that there are different therapies available in different regions. So by understanding the pathophysiology, you can pick and choose therapies that are available in your region and your hospital. So I'm going to come back to the stomach, which is a very complex organ. So when we think about the stomach, it does more than just empty. Dr. Amanda talked about earlier the fundus, where there's the accommodation, the antrum that works on grinding the food to particles less than 2 millimeters, the pylorus, which acts like a valve, and there's a pacemaker of the stomach. Just like in the heart, there's a pacemaker. And when you swallow that food, there's relaxation of the stomach to make room for the food. Now, this digestion and titration of the food is under a very complex mechanism. As you can see here, that there can be abnormalities anywhere along the way that can drive symptoms. So you can have impairment in gastric accommodation, abnormalities in the contraction. And then there's the autonomic nervous system, where the vagus nerve, which is the rest or digest, if you have abnormalities in the vagus nerve or too much sympathetic nervous system, which happens in settings of stress, that can alter GI physiology and give rise to a number of symptoms that we see here, including all the symptoms that Dr. Mori talked about in terms of diagnosing functional dyspepsia. And then when you dive down at the cellular level, what you see are that there are 4 layers of the GI tract. There's the mucosa, the submucosa, 2 layers of muscle, and then in between the layers is the enteric plexus, there's the immune cells, and then you can see the innervation from the autonomic nervous system. And again, if you have abnormalities, whether in the enteric nervous system, the extrinsic autonomic nervous system, or in the smooth muscles, that can lead to altered pathophysiology. And what we see are really 2 diagnoses. So far today we've been talking about functional dyspepsia. And you see the symptoms of functional dyspepsia there, where there's a frequency and duration to the diagnosis. But also there's a condition called idiopathic gastroparesis, and there's a lot of overlap between functional dyspepsia and idiopathic gastroparesis. The cardinal symptom of gastroparesis is that there's nausea and vomiting, but you can also see that there's fullness, early satiety, upper abdominal pain. One of the differences between functional dyspepsia and gastroparesis is that you must have delayed gastric emptying, so objective evidence of delayed gastric emptying and absence of mechanical obstruction. And there was an international consensus when we tried to decide, what are the symptoms that are necessary to make that diagnosis of gastroparesis? And the one thing that we agreed on, this was a group across the world. There were very few things we agreed on, but the one thing we agreed on was that you must have nausea as a symptom for gastroparesis. So if you take all these pathophysiologic abnormalities together, let's compare the similarities and differences. Now, because the diagnosis of gastroparesis requires a delayed gastric emptying, 100% of patients with gastroparesis have delayed emptying. But 23% of patients with functional dyspepsia will have delayed emptying. When you look at impaired accommodation and visceral hypersensitivity, there's similarities there. So how do I put this together? I think of functional dyspepsia and gastroparesis as distinct and overlapping conditions. So for patients who have epigastric pain syndrome and they have normal gastric emptying, these are clearly patients with functional dyspepsia. And then on the other side, patients with predominantly nausea with minimal abdominal pain, and they have severely delayed emptying, these patients are clearly in the gastroparesis. And then everyone else is in between. So when is it necessary to differentiate between functional dyspepsia and gastroparesis? When you look at the two diagnoses side by side, we always start with dietary recommendations. There's pharmacotherapy, and you can see that the therapies that we use are very similar. And then there's a complementary alternative therapies like acupuncture and herbal. So again, very similar. So there's really not a need at this point to differentiate between functional dyspepsia and gastroparesis. However, when you start thinking about more invasive therapies like a feeding tube, pyloric intervention, gastric electrical stimulation, or gastrectomy to remove the stomach, you want to make sure that you confirm the diagnosis. So you see here, this is the approach to patients with upper GI symptoms. Most importantly, you want to make sure that you're not dealing with an organic disease. In Asia, especially here in Vietnam, you have to be careful about peptic ulcer disease, H. pylori, and gastric cancer. So you want to make sure you rule out those alarm symptoms. But if the endoscopy is normal, there's absence of alarm symptoms, you can absolutely make the diagnosis of functional dyspepsia. And then what do you do? So you're seeing two guidelines here. The one on the left is from the US and Canada. The one on the right is Asia. And where you'll see the difference here is that in the US, the first-line therapy is a proton pump inhibitor. In Asia, it's the same with acid suppressive therapy, but within the first-line therapy, there's also the prokinetics, like aclotiamide, and the herbal medication, Riconcito. Riconcito is now available in the U.S., but it's not widely available, and there's limited prokinetics in the U.S. And so in this meta-analysis from the U.S. and Canada, what we see is that proton pump inhibitors are more effective than prokinetics in the treatment of functional dyspepsia. A little bit on Riconcito. It's an herbal blend that stimulates development, and it has multiple effects, and it's been found to be effective in both functional dyspepsia and gastroparesis, so it is an option if you have that available to you. And when you look at the symptoms that are benefited by the use of Riconcito, there's abdominal pain, heartburn, and the bloating or abdominal distension. Now, we mentioned earlier about the different subtypes of functional dyspepsia. And there was a mention of tricyclic antidepressants, which is a neuromodulator for pain. And this was an old study by Nick Talley, and they looked at amitriptyline and functional dyspepsia and the different subtypes. And back then, we used to call EPS the ulcer subtype and the postprandial distress being the dysmotility subtype. And what you can see clearly is that there's a difference in response to therapy, and that those with the epigastric pain syndrome are more likely to respond to amitriptyline than those with the postprandial or the subtype. And when you look at the gastric emptying test, those with normal gastric emptying are more likely to respond to a tricyclic antidepressant, while those with delayed emptying are less likely to respond. So when you put this together, when you look at the number needed to treat, you can see the differences here between proton pump inhibitor, tricyclic antidepressant. And where the biggest difference is in the prokinetic between the East and the West, where in the West, we really only have metoclopramide as our only available prokinetic. So when you get to second-line therapies, of those who are not responding, how do you think about which medications do you choose for second-line therapy? So what I took here was I took the predominant symptoms and some of the pathophysiologic abnormalities For example, with fullness, you can have impaired accommodation, visceral hypersensitivity, and delayed emptying. With bloating, you can see impaired accommodation, delayed emptying, and something called abdominal phrenic dysinertia, meaning the diaphragm does not move appropriately, nausea, and abdominal pain. So again, what you're seeing here is that there's some pathophysiologic abnormalities that are associated with certain symptoms. So when you don't have availability of gastric emptying or gastric aerostat or scintigraphy to measure these physiologic abnormalities, you can try to use the symptoms to determine what might be going on. So if someone has impaired, or you're suspecting impaired accommodation, a potential therapy is buspirone. It's a 5-HT1 agonist, and it increases gastric accommodation. And what you see here is it improves symptoms of fullness, bloating, and nausea in those with functional dyspepsia. Metoclopramide or domperidone works centrally. So I'll talk about this later this afternoon, but when someone has nausea, you think about what the mechanism is. And metoclopramide and domperidone blocks the activation of the chemoreceptor trigger zone in addition to the prokinetic effects. And again, it improves nausea, vomiting, and bloating, but it really doesn't help with abdominal pain. So thinking about the mechanism of action of the drug and the potential physiologic abnormalities, we can choose the therapies appropriately. Prucalopride is a prokinetic in the U.S. It's FDA approved for chronic constipation. It does accelerate gastric emptying. And in this study of gastroparesis, they found that it helps with nausea, vomiting, fullness, bloating, and reflux, but does not help with abdominal pain. There's been mention of brain-gut therapies, and what's the mechanism of these brain-gut therapies is it decreases that sympathetic activity. So the sympathetic nervous system is that fight or flight. So if someone is chronically stressed, anxiety, poor sleep, the sympathetic nervous system revs up. And therapies like hypnosis, cognitive behavioral therapy, mindfulness, relaxation training, all these therapies can help reduce the sympathetic nervous system. And here's a meta-analysis that's showing that these therapies are effective in helping to reduce symptoms in disorders of gut-brain interaction. And finally, I want to leave with the idea that for all patients with upper GI symptoms, you should screen and treat constipation. And why is that? One, there's something called the cologastric reflex, which is that when you have distension of the colon, it slows gastric motility. And we see that patients with upper GI symptoms commonly have constipation. And we saw this in a study using wireless capsule motility that we found about a third of our patients with upper GI symptoms have delayed on transit. And when we treat their constipation, their upper GI symptoms improve. So how do I approach functional dyspepsia? First, to make the diagnosis. I do empiric proton pump inhibitor. Try to determine if their symptoms are more postprandial distress or epigastric syndrome. Most of the time we see an overlap, so you can mix and match the therapies. And then the agents that I use. If they have more bloating, early satiety, I'll use buspirone, prucalopride, metoclopramide. If they're nausea, metoclopramide, promethazine, and etc. And oftentimes if they have overlap, you may need to augment and potentially use prucalopride with like a neuromodulator. And so, again, when you have someone with upper GI symptoms, I think, what are the predominant symptoms? Like if it's pain, I think of functional dyspepsia, kind of the EPS subtype. If it's nausea and vomiting, I think gastroparesis or chronic unexplained nausea and vomiting. Again, most of the time what we see is this overlap where they have more than one symptom and you think of functional dyspepsia or potentially idiopathic gastroparesis. But the treatment, again, you don't need to do a lot of testing. You can start treating based on the symptoms. But once you get down here into the more advanced therapies, more the surgical intervention, if you want to stop, pause, and confirm that you have a diagnosis of gastroparesis. And I'm not going to go into this in too much detail, but when you diagnose gastroparesis, you need to make sure you have three things. One is that they have the symptoms of gastroparesis. Two, they need to have a normal endoscopy. Three is confirmed evidence of delayed gastric emptying. And this could be scintigraphy, breath testing, or wireless capsule motility. And again, I'll go over this in more detail this afternoon. Okay, so the key takeaways here is that there's a lot of overlap between functional dyspepsia and gastroparesis. Really what you want to do is treat based on the predominant symptom and the severity of the symptom. So if someone has mild symptoms, even if you have gastroparesis, you would not send them for surgery. And then consider the pathophysiology when considering the treatments and augmentation so that you can choose the appropriate therapy based on the mechanism of action of that therapy. And again, make sure that you're confirming the diagnosis of gastroparesis when you're considering surgical intervention. And thank you.